And welcome back. So guys, we're going to continue talking today about COVID-19 and exactly how this disease is going to impact different organ systems in the body. And today we're going to talk about the heart. Now, again, as I mentioned in the introduction section of these revision sessions, we know that other systems are going to be affected, not just the lungs. Okay, and what we're going to look at today is effectively if there are comorbidities in a certain tissue, then there's going to be more damage. And if there's more damage, then there's more risk of mortality, basically. We'll have a look at some data. This isn't going to be too in-depth. We're just going to have a little snapshot of it. I have the papers where I've taken these figures from linked in the description on Blackboard Learn. So please feel free to have a look at those papers. So I've just started off with a figure here showing different organ systems and structures that can be affected by COVID-19. So obviously we have things like pneumonia, renal failure, diarrhea. Okay, we can have septic shock as well in the heart. And the heart is really what we're going to talk about today. Okay, so I'll probably be introducing this figure anytime we're talking about a different organ system. So right off the bat, guys, I want to introduce us to some data. Now, this is going to show, this is Chinese data, okay, from the CDC, and this is some early data. Okay, we have A is going to effectively be the confirmed cases, and B is going to be the confirmed deaths in this cohort where the N number is 20,000. That's quite a good set of data that we've got here. Now, what we can see from this data set, let's enlarge it a second. What we can see from this data set is, if we keep our eyes on the blue section for a second before we go into detail, roughly 75% of patients have no comorbidities. 75% have no comorbidities, which means then, so none here. Okay, that means then none in blue. That means that of these 75%, none of them had a comorbidity rate, which means these 75% of people may have had a fairly milder disease. Okay, we can't really test this. We're not testing symptoms here. What we're testing is there a comorbidity in this patient set. That's 75%, that number. If we look at the confirmed deaths, though, you can see that of the people that have died, and that number is 504, you can see that there's roughly 26% of them had no underlying condition, which means then 75% of people, roughly speaking, okay, 74% of people had an underlying condition of those people that died. All right, so hopefully we can start to relate then the amount of people that are dying and a comorbidity we can correlate those two things. Okay, so we've got a breakdown here of hypertension, cardiovascular disease, diabetes, some chronic respiratory disease and cancer as well there. And what we can see from the data is that hypertension, if we just look at deaths for a second, because these are really the patients that are most severe. These are the patients that are going to be administered to the ICU. They're going to require some critical care. 31.9, so about 32% of people had hypertension of those people that died. That's quite a large number considering that the total people who died are 500. Okay, so 32% of these people had hypertension, and maybe that's the reason that they died. So high blood pressure, hypertension, right? 18.3% of them had cardiovascular disease, generally speaking. 15.9 had diabetes, so that shows that maybe diabetes is going to be a risk factor. All of these things are risk factors, right? Chronic respiratory diseases, though, 6.3%. So, although, again, I'm reiterating that idea that we like to think of this as a lung disease, as a pulmonary disease with pneumonia, but of the people that died in this cohort, and 20,000 is quite high, we only see 6.3% of them having chronic lung conditions, which is fairly interesting. But you see most of the conditions, with hypertension, cardiovascular disease, okay, diabetes to some degree as well. Diabetes and hypertension could be sort of linked, really, if you think about it. Okay, they're risk factors for each other, aren't they? Okay, these two, okay, risk factors as well, and CVD. Whereas chronic respiratory disease, okay, and that's generally speaking, okay, a little bit lower. So we just have some data sets there to show us that we have some comorbidities that are associated with coronavirus. If we move on to the next figure, okay, we actually have an idea of how this virus may be actually working now. Okay, so we'll just start off at the top. Okay, so we'll have a look at the actual virus itself. Now, you guys will cover this a lot more probably in other revision sessions. We're going to briefly cover it so we have an idea, and at its heart, what we can see is that we're going to have the spike protein, or the S protein, along with some other proteins as well, are going to, this is a trimer actually, it's going to bind to the ACE2 protein that's presented on a lot of different epithelial tissues, okay, in the body, and it's going to enter the cell. As it enters the cell, it's going to replicate its viral RNA. This is a positive sense single-stranded RNA virus. It's going to replicate and produce its own proteins, and then it can replicate and replicate, and that's how these viruses work. Okay, that's how these beta coronaviruses work. Now, we're going to have direct damage of the cardiovascular system and the respiratory system as directly, because this virus entering cells, those cells that have the virus are then going to be infected. They're going to be more predisposed to apoptosis or programmed cell death. Ideally, lymphocytes and other immune cells will sense through recognition sites and chemokines and things like this. They will and cytokine profile. They will recognize which cells have the virus inside them. All right. If the white blood cells know which cells have the virus inside it, they will mount an immune response on its own cells because it's now infected, and kill it. And that will be the idea. If you stop the cell, stop the cell's machinery from working. So the ribosomes, basically, the viruses do not have ribosomes. They need our ribosomes to make their proteins. That's why they're viruses, right? So if you kill the cell, which has the store of ribosomes, then you're not going to get any more viral proteins. So that's the idea. If our white blood cells can kill or induce, let's just say, instead of kill, it's a bit of a simplified term, but if we can induce programmed cell death in those cells through a couple of different mechanisms that we're not going to go into, different signaling pathways and such, we can then reduce the viral load, the viral number. Okay, so that's how we're going to get some directed damage, okay, in the lungs, in the alveolar tissues, and in the myocytes over here. Now, we can also get, so direct damage, we're looking at the heart, keep in mind, so we're going to get direct damage, okay, we're going to have a look at the renin-angiotensinogen aldosterone system a bit later, which we looked at in the renal lecture, so feel free to have a look at your previous lectures that I taught you guys to just revise on that topic. The RAS system, remember we look at the kidney and how that's going to regulate blood pressure by secreting renin, and then the liver converts the renin, all of that stuff. Have a look at that. That can also lead to damage of the heart. Now, because we have damage as well as the heart, we have lung damage as well, that's going to result in hypoxia. And what we may have is hypoxia-induced myocardial injury, which means that basically there's not enough oxygen anymore because there are infiltrates and lesions inside the lungs that are going to lower the oxygen carrying efficiency. You know, so it's basically going to reduce the Bohr effect, okay, of taking in that oxygen, okay, and the red blood cells holding on to that oxygen. It's going to reduce that effect, isn't it? Which means then that the heart tissue has less oxygen. If the heart tissue has less oxygen, it's more likely to be damaged, okay, and it will not work as efficiently. Okay, we're also going to get some intracellular acidosis as well. Lactic acid as well is actually lactate is quite high in patients with COVID-19, oxidative stress. But looking at existing coronary conditions, though, if there are existing coronary conditions, which means that we have maybe decreased perfusion, which is the amount of blood that's going to the tissue because of, say, atherosclerosis, if there's so any form of blood vessel disease, if there is a previous history of heart attacks, generally hypertension as well, you know, so especially if there's already some form of necrosis on the heart, that's definitely going to be bad because we're going to have reduced oxygen carrying capacity anyway to the heart, and then you have more of it now because of this virus, which is just going to be very bad. Okay, so we can have a look at things like other conditions that you could have. Okay, there's some other figures we could go through, but some heart conditions, okay, things like atherosclerosis, myocardial infarction, cardiomyopathies, okay, maybe some hypertrophic cardiomyopathies, myocarditis, things like this, okay, can also affect it. And we're going to have a look at how COVID-19 can actually cause myocarditis and other conditions in a second as well. And then what I want to finish on, because this again is just a fairly basic introduction, is some histology slides. Okay, we love a bit of histology, don't we? So we've got 4 sections here. We've got A, B, C, and D. From the figure, I'll let you read the title down here. Okay, this is linked in the description. Everything that I've shown you guys is linked. The papers are linked on Blackboard Learn, so please click them, and there's a little short description to show you where I got each of them from. We've got A and B, which are lung tissues. So A and B are lung tissues. C is going to be liver tissue, and D is the striated cardiac tissue there. Something you can see instantaneously with all these tissues, guys, is that we have these purple mononuclear cells, okay? And these mononuclear cells are mononuclear infiltrates. If we just zoom in on the lung quite a bit, okay? We'll just have a look at one of these lung sections, okay? What we can see, there we go, we'll just have a look at A for a second. What we can see is that they're dotted around everywhere. If we zoom in, we can really see these mononuclear cells. One nuclear cell, really. These are lymphocytes, are mainly what we're going to be looking at here. These lymphocytes are causing, or they are rather, inflammation. So what we're seeing here, all of these mononuclear infiltrates, is that this is a site of inflammation and damage. And actually you can see alveolar tissue damage here, because it looks very disrupted. It doesn't look very there's not much of a structure to it anymore, because of these lymphocytes damaging, and the viral tissues, viral replication is damaging tissue. As we can see with B as well, we actually have more of a structure. You see more of these alveolar cells actually remaining intact compared with A. You see a lot of diffuse damage here, but with B you can see some of it is still actually intact. And again, we still see some of these, we see a lot of these mononuclear cells over here, right? Same can be said for the liver. Okay, let's do that. Okay, same can be said for the liver. We have our hepatocytes with these mononuclear cells down here. And then the cardiac is where the cardiac cells, the cardiomyocytes, is really where we're going to have a little look. Okay, so let's just zoom out a second. So having a look at these, I'll move myself. There we go. So having a look at the heart tissue now, what we can see is that there is actually relatively less. If you look macroscopically at the cells, you can see that there is relatively less of them compared with the lymphocytes in the lungs. Now, what this tells us is that maybe there's actually less lymphocytes infiltrating the heart of this particular patient, okay, considering this is one biopsy. This isn't representative of all the biopsies of a COVID-19 patient. This is simply one biopsy in one patient. But we can still draw some conclusions from it and maybe mount some hypothesis, which is really what we should be doing with this, with what I'm doing here with you guys. So we still see these mononuclear infiltrates inside the myocardium, okay? Now, the point that I want to stress here is that if this tissue is healthy, which means all the cardiomyocytes are working as they should, okay, let's just say this person is a early 20s female, let's say, that would probably be a very good category to be in, being that males are more predisposed to, or they seem to be doing worse with this condition than females. Let's say this is an early 20s female, her heart works great. Yes, she has some mononuclear infiltrates because she has COVID-19, but because she has no underlying conditions, she can deal with it. She can deal with those lymphocytes infiltrating her heart, and she can she can fight this infection better. The lymphocytes are there to lower the viral load and kill cells that have any virus inside them. Okay, so that's why they are there. So it's really a good thing, but it's the purpose of this. What we're going to talk about as well, being that something called the cytokine storm or cytokine surge can actually cause inflammation, and it's a very positive feedback generating loop. Okay. It's not very good, is it? Positive feedback loops for pathologies. Now, she'll be able to deal with this. Now let's go the other end. Now let's say we have an elderly male who has some form of cardiomyopathy or he has had a heart attack in the past, he has the same level of lymphocytes or mononuclear infiltrates in his myocardium or pericardium, will that person be able to deal as well as the early 20s female? No, because there is already heart damage. Okay, so what we can see here is actually there's some damage here, damage to the striations already. You know, so maybe there's some damage already here. Okay, so this is the point I'm trying to make. Okay, if there is a pre-existing condition in the heart of somebody with COVID-19, then they can't deal with these mononuclear infiltrates. Okay, and this is how the damage is set up in tissues. What you're looking at is precisely how COVID-19 damages tissues. Okay, this is precisely how it's doing that. Okay, so hopefully this has given you some good insights into how tissues are getting damaged by COVID-19. It's not specifically that the virus itself is causing the tissue damage, it's that your body's response to this virus with these mononuclear infiltrates, everything that you're seeing on screen here, okay? Everything that you're seeing on screen is the body's response to this virus, and it's trying to lower the viral load. In doing so, the virus has its own mechanisms as well that we could talk about in future sessions that set up these lymphocytes doing more damage than good. All right? Good. And when if we're just talking briefly about some other conditions that could be here in terms of the heart, we could have things like myocarditis, which is actually some of these lymphocytes infiltrating. So what you're seeing here is actually some form of myocarditis, okay? Because we have lymphocytes in the heart, that's not really ideal, you know. We could have there's been a case. So in one of the papers that we're looking at that's linked, there's a case of a 47-year-old patient. I believe female as well. She had no prior condition of cardiac disease. However, because of other factors, okay, that's not simply the be all and end all, right, guys? Like, if someone has a healthy heart, doesn't always mean that they're going to not have any heart complications. It just means that they may be at less risk of having any serious critical illness or cardiovascular consequences because they have a healthy heart already. Doesn't mean it can't happen, okay? So there was a case of a 47-year-old woman, I believe, no prior case of heart disease. However, she suffered with the histology presented with myopericarditis, okay? So in the pericardium, if you look at the cardiac lecture, the pericardium that's just on the more visceral layer of the heart, not inside the heart, there was inflammatory infiltrates in there, so it was damaging the pericardium. Okay, and then you'd get inflammation in the pericardium, leading to swelling and other problems with cardiac output and things like this. Okay, so just a visual guide, and really I'm liking talking about the histology here, if I'm honest. So there are other things we're going to talk about in future sessions, such as heart failure as well. We're going to look at some numbers, we're going to look at some actual figures, and we're going to talk about things like the renin-angiotensin aldosterone system and how we can manage blood pressure and how blood pressure is altered in this disease. Thank you.